understanding the nature of trauma, which we are delighted to welcome our 4 expert speakers, because it's so important that as journalists, writers, authors, we get a thorough and good understanding of all our subjects that we're writing about, and that is the purpose of our events, to enable journalists to be informative, positive, and tackle challenging subjects in the right way. And I don't know, I mean, trauma is so topical, it's around us all the time today, and if, like me, when you turned on the Today programme this morning to get your news, of course you have other outlets available, you may have heard the story of the ex-soldier who has just been discharged from duty from the armed forces, who was driving along the A40 when a plane crashed on the A40 yesterday in front of him, and despite all his personal problems, he was programmed to leap over the central reservation, and with another man who got there, take the people from the wreckage, and everybody was rescued. That perhaps is a dramatic sort of event that people think of as trauma, but it's been described to me by experts as a very elastic condition, so that it can be physical, mental, emotional, as we know, and that both in causes and in manifestations. So we're going to learn much more about that this evening from, as I say, people who are the true experts. And none other so than Noel McDermott, who has kindly sponsored the event this evening, and who I'm sure you'll all be fascinated by his own personal and professional expertise in the area. And Noel will be our first speaker. All the information about our speakers are on your chairs, with biography, contact, some published papers and further information. Also out on the desk where you registered, there are lots of leaflets to pick up as well. So welcoming here Noel McDermott, as I said, and Dr. Jonathan Leach, Dr. Angela Kennedy and Dr. Stephanie Lewis, who will be taking their turns at the podium. Sorry to have stood in front of you, Neil.
No, not at all. Sorry to stood behind you.
Okay.
Made you very anxious. Hi, my name's Noel McDermott. It's great to be here, that's my name. We're sponsoring this thing, which is great, but I sort of don't really think that's why I'm here. It's not because I'm sponsoring because it's such an important subject, and it's really important, this audience is really important, that you get really grounded, evidence-based information about this subject, because it seems everybody has trauma at the moment, and I'm not quite sure that's true. So we're going to be talking about what that means, what trauma means clinically. I'm not going to talk about it personally. That was the job I was given, was rather than do a presentation with slides and talk about the science of it, which is what we're going to hear about. It's to talk about it personally, what it's like, and to maybe give a story of hope as well. When dealing with trauma, and if you do deal with it, if you do come across it professionally, I think it's really important that you think about your own needs within this. All the clinicians here understand the issue about secondary traumatisation, about taking things on, becoming overwhelmed or becoming hopeless. And sometimes when you hear the types of stories that you can hear around trauma, you can really find it very difficult, and it can have sort of impacts upon yourself. So I hope you will be thoughtful about your own needs, and careful with yourselves and kind to yourselves in any of the stuff that you report, particularly as people who may see these things at first hand. Be aware of your own needs, and if you get any of the symptoms that you hear, go and have to talk to somebody about it, for goodness sake. So physician, heal thyself, I think. So I was asked to talk personally, so I will. Just a trigger warning here. I like to be sensitive to that. Some of the things I might talk about might be quite upsetting to hear. So if it does seem like that, just put your hand up and I'll draw it back if somebody wants to join us. Right. So where do I come from in all of this trial? I happen to be a psychotherapist, and I think the reason I became a psychotherapist was it was probably the only way I was going to help myself. And I think there are a number of people in the helping professions, mental health, that come into it like me, with our own profound needs. And very luckily we get those met. I did. I'm very grateful for that. These days, as my colleagues are going to talk about, the range of services that are available are much more available now. When I was younger and all this stuff was happening to me, dinosaurs were still walking the earth, and the range of services and the types of services that you might get were not as good and coordinated and understood because of the work of fantastic clinicians like this. It wasn't as well understood or put together. So what's my story? Why am I here? Why am I passionate about this stuff? At the beginning of Mental Health Awareness Week, I grew up in an immigrant family, very poor. There was daily violence from my mother, and daily violence from my father towards my mother, and daily violence between siblings. My father is still an alcoholic, and he currently has what's called Korsakoff's, which is brain damage that comes from drinking too much, and he has a group of very courageous care people around him. I wouldn't go anywhere near him personally. He was a very violent, very frightening man, very disturbing to be around, and I was very grateful when my mum left him when I was the age of 8, which was unusual in those times. As I said, it was way back when I was a latchkey kid. I don't use that term these days, but I was. Apparently I was a social problem growing up. I was a latchkey kid because my mum had to go out and earn the money, because my father certainly wasn't going to do that. Or if he was going to earn it, he was going to drink it. And I do remember as a child going to pubs when I was a kid and trying to get the wage packet out of my dad before he drunk it all. Because for one day a week he would feel like a king and would be out there. Fantastic. Thanks very much, Dad. He was so excited when I was born, he gave me his name. I was the firstborn son, and there were 3 girls before me, so he called me by his name, so his name is Noel. I was terrified as a guy, is the truth, you know, and grew up with that terror for a long time. On reflection, he never was violent towards me, but I would say about this, or to any of the kids really, but he was violent to my mum, and to a child, you can't tell the difference. You just can't, which is why the Children Act was changed after the Climbier inquiry, so that now children witnessing domestic violence are assumed to be experiencing physical abuse. So that's now part of the Children Act and the assessment. I spent many years working as senior manager in social services, dealing with all these things, and also I spent many years working in inpatient and outpatient psychiatric settings, working with forensic patients who are very scary indeed. That means people who've gone through the criminal justice system and been sent to hospital rather than prison. And interestingly, when I first started my practice up in Scotland, we were talking about this in the Royal Edinburgh Hospital, in the forensic service there, I actually felt at home. It was mad interesting. Amongst all the kicking off and the chaos, I had developed some really good coping strategies that enabled me to be in highly frightening, chaotic situations and function very well. Unfortunately, they weren't transferable skills to normal life, which would have been useful to have. But when the patients were kicking off and the alarms were going off and we were thundering down the corridor to sort out the BRMs, all of that sort of stuff, I was in my element. And I was thinking about that when you said about this plane crash. Because one of the skills I had was dealing with a crisis. Always. It's automatic, absolutely automatic. And I lived with what's called, and I'm sure we're going to talk about this in the slides, I lived for many years with what's called disassociation, which can be manifested in various ways. Mine was experiencing the world as though looking through a thick pane of glass. So everything was a little bit distanced and a little bit dull, and I was a little bit cut off. But I could become very cut off, and I become numb with the disassociation, which was a fantastic gift as a child, because if I hadn't had that ability to shut down and cut off, it would have been far too much for me. And maybe I'd have gone into much more destructive patterns. The patterns I went into to deal with it were relatively destructive. I was gifted alcoholism by my family, by my parents. And again, there's an interesting connection with trauma. We tend to think of alcoholism or addiction as intergenerational adaptation to trauma. So trauma will have happened somewhere along the various generations, and one of the ways nature has of dealing with it is to produce addiction. Another way is suicidal despair. And addiction is preferable and better survival mechanism. So again, it's there as a reason. And so I dived into my alcoholism and my addiction as a way of initially sort of managing the symptomology, which people go into very well. So flashbacks, imagining I was in situations again, and depression and anxiety, and also some of the less well understood ones, such as losing my temper all the time and being very violent. After I had all my trauma treatment, which I have and I'm very grateful for, I don't lose my temper. I'm not antisocial, I'm not violent, and it's not naturally part of me. And I think there's a lot of, in some of the stuff we were talking earlier on, weren't we, about the work in South London that we've both been involved with, and the kids, and we'll hear more about this. They're not pleasant. These kids that have trauma are just not pleasant. They're actually quite frightening and upsetting, and do really quite crappy things. And it's very easy to reject them, and it's very difficult to find the services that will work with people with trauma. Ex-soldiers, they're not pleasant to be around when they're in a flashback back in Basra. They're quite frightening and dangerous to be around when they're in that flashback. The amount of domestic violence that happens as a result of this. We were just talking about before, I do think it is one of the biggest crimes, the way we don't support our ex-service personnel. I think it's awful. I think it's dreadful. And there's a lot of work to be done, and it's fantastic. In terms of people developing long-term mental health problems from early trauma and other forms of trauma as well, which I know that you're going to go into, and people being misdiagnosed all the time. I'm working with clients at the moment who was admitted under the Mental Health Act, Section 3, and diagnosed with psychosis, and it's got nothing to do except as an expression of the trauma of this person. And we're now currently fighting to get him re-diagnosed, because any time this guy has a dip in his behaviour and his problems, he's going to be thought of as somebody who needs to be sectioned because he's already had one, which in itself is a very traumatic experience. And we might go, I don't think we're going to go into the Mental Health Act, but personally I think it needs to be really overhauled and looked at very seriously, as it's causing a lot of damage. So my experience was then I used alcohol and drugs and various things to try and manage these symptoms. In my 30s I was very lucky in that I met somebody that I fell in love with, and she introduced me to a feeling I'd never had before. What she did was she gave me an MDMA pill at a party. And I didn't know. I was very scared of drugs. Alcohol was okay, so getting to blackout drunk 7 days a week was okay, but drugs scared me. But anyway, I trusted her. She gave me some MDMA. And I had this strange feeling, and this strange expression came across my face. And I said, wow, what's this? And she said, oh, that's happiness. Oh, I like that, genuinely. And it was the first time I can remember happiness. And it was chemically induced. Luckily, I didn't make a dumb decision, which was to think that only chemicals produce happiness. But at that point, I'd had something that people were talking about that I had no idea existed. I'd heard about these words, happiness and fulfillment and all that sort of stuff, but they were beyond my experiential realm, so they were intellectual subjects. But from that experience, I then tried to find that again, because I thought, and it's a very nice thing. Lots of you have happiness a lot of the time. It's really worth having if you don't. And I mean that very seriously. It's well worth pursuing. And contentment and warmth and love, and these things are great things to have. But if you've never experienced them, and in fact if you've experienced the behavioural side of those things, like a parent pretending something to then hit you or frighten you, you would actively react against these types of things, and the sort of training that you get away from those as you become more and more antisocial. But anyway, I had this experience. I thought, I like that. And then the professionals I was working with explained to me that really the way you get that feeling is by having the treatment, but getting to know people and learning how to get on with people. And they were really smart because they were right. And it took a number of years, and I did learn, many of you maybe naturally have this, but I learned to become social. It was not a natural skill for me at all. And I was taught painstakingly how to socialise with people, how to talk, how to look in people's eyes, because I was very afraid of eye contact, how to not invade people's space, how to be warm, contactable, connecting, etc., etc. I liked it so much. What's that old Remington? I bought the company, so I went and trained as a therapist because I thought, this stuff is great. This stuff works. And for a while in my life, I could drink and I could function in that area of my life. And that area of my life, the professional area, was fantastic. It was where I felt alive and warm and connected. Outside of that, forget it. It's not happening. Eventually, of course, as a drink does, or any drugs do, it stopped working. And I came to 42, and I was in a rock and a hard place. I just didn't know what to do. And what was happening for me was actually my work was beginning to suffer. So that bit where I'd constructed my humanity was at risk. And so I was then left with a choice. And the choice was very simple: stop using and go straight and clean, or give it all up. By then I had something worth losing, which was my humanity. And I'm very grateful for that the professionals taught me how to be a human being. And my profession taught me how to be a human being. And I valued it at that point. I was very grateful for that, which gave me the courage to stop drinking, which I did 10 years ago. And actually, it was really easy. I'd made it all up in my head. I really had made it up in my head how difficult it was. I remember I went to rehab by day 3. I was detoxed from the alcohol. I came off the benzodiazepines, and I went, oh, is this it? Okay, all right, great. And off I went. And I can honestly say that up till that point, interestingly, I just still told you I was traumatised. But that was good reason to drink, you see. But at that point, I realised that all the work I'd done had worked. And it was just simply about not drinking anymore, which I did gratefully 10 years ago. And I still don't. And I love it. My life has blossomed. I was just texting my partner, sorting out some childcare stuff. I might get emotional. I might actually feel some feelings, so excuse me. That's not possible for me. For somebody like me, that's not possible. Normal is not possible. It's a distant dream, a very distant dream. But it's something that has been gifted to me, and it's really extraordinary. And my colleagues here offer that to people. And it's an honourable thing. It's an extraordinarily honourable thing, and I think something to be very proud of. And we do it well in this country. We do it well. We're good at talking ourselves down, but in this area of work, we do it well. Psychiatrists in the UK started in World War II looking at this issue, changing the name from shell shock to something else, and began experimenting with exposure therapy and working with soldiers, so soldiers were no longer shot as cowards, which is what we'd done to them before. Soldiers with post-trauma syndrome, we'd shot them and called them cowards. And I think 2 years ago, one of them finally was given a pardon from World War I. So it's an honourable profession, and I'm not quite sure I'm in the same league, but I'm sort of nice to be thought of in the same sort of company. I'm very grateful to be here. If I don't mention the company, Teresa's probably going to give me a kick in after the show. So I do run some companies, and if you want some information, come and have a chat about it. I'm not really here to promote them tonight, except to say this, that I'm so passionate about helping people to become who they want to be, to fully realise themselves as human beings. And what annoys me is that we know how to do it, And that's all we have to do, is get out to people and teach them how to do it. We're really good at it these days. We're really good at helping people. So if you don't mind me saying, your job is to let people know that we're really good at this stuff, and to teach people that and ask them to ask for help. So thanks lots of it. All right?
Thank you, Noel. That was... We're going to have questions and be able to chat to our speakers on the panel when we've finished hearing from everybody, and then of course network more afterwards. But Noel has now left the floor, and so Jonathan is going to tell us about that very difficult process of diagnosing and starting people on their journey.
So thank you very much. I'm very grateful to be here this evening. I think when I was approached, I thought this was a really, really good opportunity. There are lots of misconceptions we were discussing around psychological trauma. I also think in terms of physical trauma, obviously, they can be linked. I'm also very conscious that this is a very sensitive subject, actually, and then if we look at the number of people who suffered psychological trauma at some stage in their lives. So I'm just very conscious in terms of a general audience. I've not met any of you before, but if you feel, it's all a bit sensitive, then feel free to leave or something. We can chat afterwards. I'm just really, really conscious of this subject. Okay. So what I'm intending to do the next sort of 10-15 minutes is really just talk you through some of the medical aspects. I come from a slightly different background. I was reflecting when I went to my 35th, not wedding anniversary, medical school anniversary last year. How long ago I qualified? I'm that old. But actually, I have a very different background in that after I qualified, which was from Sheffield University, I elected to join the army. And actually, much to my surprise, ended up serving for 25 years in the army. 17 years of which were overseas. Some very nice places like Hong Kong and Cyprus, but also I did operational tours in Northern Ireland, in Yugoslavia, in Iraq, and a bit of Afghanistan. So, I've seen that. And then when I left the army, actually I worked for West Midlands Ambulance Service. I'm now a GP in Worcestershire. So I flew on the air ambulance there and saw quite a lot of things. And actually when I reflect upon, I'm not quite ready to retire, but when I reflect on my professional career, I've seen some of the most brilliant things. I've seen babies born, I've seen people cured in my military career, and actually also in the ambulance service. I've seen sort of amazing acts of bravery. We were talking about the soldier who went forward to the air crash recently. But I've also seen some of the most terrible. I've seen people being badly injured, I've seen their families. I responded to Zeebrugge when the Herald of Free Enterprise tipped over. And if I just see how I feel about this, I reckon that was probably one of the worst weekends of my life. Okay, just the effects on people. And I think that, whilst I will put a professional face on, we're all human and we all have these effects. Okay. So I'm going to try and give you a perspective really from NHS general practice. I'm going to give you a perspective from military general practice. The cases I'm going to tell you about are real. And my patients, I know them, I know some of them quite well, but clearly for reasons of confidentiality, I've changed quite a lot of the detail, but you'll need to take my word for it, that the detail is correct on one of them I saw last week. Okay? So I thought what I'd do is try and embed this in real clinical stories, because I think that will hopefully bring it alive. First one, we'll call her Sam. She's a 28-year-old lady who I first started seeing about 4 years ago. She registered with our surgery in Bromsgrove, and actually, she came along saying, "Can I have my antidepressants, doctor, please?" So I've got this sort of rather inquiring mind, so why are you on antidepressants? And one of the things was actually that she was started on antidepressants as a teenager. Now actually, that's quite unusual, and you will hear that probably from Stephanie later. It's quite unusual. And so the professional curiosity, I'm just nosy as a doctor, is why? Why were you started on antidepressants? And the story unfolded. This was a young girl who was in a terrible household where she was physically and sexually abused. I was now seeing her at the age of 24. And actually, I think, or I know, what had happened is that she'd been misdiagnosed, certainly by some of my GP colleagues. She'd been put on antidepressants because she was depressed. She was depressed because she had post-traumatic stress disorder. But one of the issues we often say is that when I look at this lady, because of all the problems that she had at the age of 14, she never did her GCSEs, she never did her A-levels. She was therefore unable to go to university or do postgraduate or higher education, which meant that this lady, never mind the huge difficulties that she has in terms of maintaining her personal relationships, actually her economic outlook in terms of what she could expect is being significantly affected. And it isn't just now, it's actually for the rest of her life. Now, I've seen her, I've referred her, because, and I'll come on to this, there are reasonably effective, they're not perfect, they're reasonably effective treatments. And I think there's one of the things that this group, you group, can do is actually to get the message out that if people have post-traumatic stress or psychological distress, there are actually some reasonably effective treatments out there, which, as Noel said, actually can really save people's lives. And I think that's a real message for you as writers. You can do that, whereas I can't. And that's one of the reasons I'm here. So I referred her for cognitive behavioural therapy. She started that and she's a lot better. But I can't undo the damage which has already been done. My second case, we'll call him George. I saw him last week actually. He's a 56-year-old gentleman. He's military, ex-military. He was in the Royal Military Police, undercover, in the early 1980s. I served in South Omar in 1984-85, that sort of time. He was in Belfast in 1982. He was an undercover police officer, and at that stage, the military had lots and lots of people who were undercover, sort of observing and watching and things like this. And unfortunately, he was witness to his lieutenant officer who was blown up, and he was shot, although actually he was shot by another British soldier because he got in the way as they were shooting. He was actually, to be fair, treated by the military at that stage, and actually he functioned quite well for quite a long time. When he left the army, which was after about 8 years, he then went into security. Quite a lot of military go into security. But he's really had a very, very bad run. So because he's been working in, if you think I was watching he didn't work for the post office, but I was looking at a cash van as I was coming in here. And actually he's now been held up 3 times by people with guns. And I think that, it's not surprising that when he comes along to see me, and actually there was an interesting thing, this is quite a common story, he was dragged in by his wife, and the story was, sort it or I'm off. And actually being brought in is such a common feature. And actually one of the comments I was going to make is we forget the family behind the patient, because actually they're the ones who are there at 2 o'clock in the morning trying to calm them down, making sure that they don't slit their wrist or put a knife in somebody. So actually there's a lot of work to be done around families. There's a lot of evidence, and Noel talked about the impacts upon him as a child, but actually there's good evidence, unfortunately, about the impacts upon spouses, partners, but then also generational PTSD. And the Israelis have done a lot of work around this, around the effects because of the environment that they may be in. And I think that perhaps is what Noel was describing, that actually there's a lot of evidence about that, the effects of that. But let's just talk about George. He's drinking, he's been on drugs, as I said, brought in by his wife. Now actually, again, the treatments are the same. But what I've done is that we've done various blood tests. I'm his GP. Okay? I may have an interest in this, but I'm not a psychiatrist, a psychologist. I'm a general practitioner, so I don't do CBT. But what I have to do is to recognise when somebody needs my specialist colleagues' help and make sure we do a referral. Okay, so that's my role as a GP. Now let's just talk about post-traumatic stress disorder. So the academic, and I've given you an article which we recently published from the NICE guidance, so you've got all that here. This is in the public domain. So technically it's caused by stressful or frightening, distressing events. Technically we make a diagnosis after a month if it starts to intrude on people's lives, but frequently, let's say, I haven't seen people after the Grenfell fire myself, but I would imagine that quite a few of those people you could have identified early on, who you could reasonably anticipate could go on to have problems. It's about 6%, 4 to 6% of the population. Actually, what's surprising is that when you look at the vast numbers of people who might be subject to things which could cause psychological distress, actually how few actually go on to get PTSD. And I think that's a really important message here. Just because, and this is particularly with a lot of evidence from the military, and I'll come back to resilience, is that just because you see something which is horrid doesn't mean to say that you're going to go on to get PTSD, and that's a really important message. So the formal diagnosis about re-experiencing, reliving, which is what Noel said, avoidance, and that's quite difficult when it comes to treatment, because the treatments you're often thinking about or re-experiencing the things. So actually it's difficult, it's hard, so our DNA rates tend to be high. So it's hard treatment for patients. Emotional numbing, dissociation, Noel described what he got, but you're in a different world. And it's part of the brain, if you like, trying to block it out. That's the way to think of it. Interpersonal relationship difficulties, common. Because often angry, people turn to drugs and alcohol because they want to block it out. Makes them happy. Keeps them away from having to confront reality. And they often have a very strong negative personal perception, so they get deeply depressed. And it's often compounded because of the nightmares by poor sleep. Sleep is a major problem because of the fact that we don't want to use things like Valium or other medications like that. Who gets sick the most? Actually, the commonest thing is that people often think of the military. Actually, it's women, unfortunately, who have suffered domestic abuse or sexual abuse. That's the biggest group. Refugees. There's evidence of emergency workers, paramedics, about 25%, some studies. Military, generally it's around 4 to 6%, but if you've been in the armed forces right at the front line, if you like, fighting, it's up to 17%. But essentially it's anybody who can suffer trauma, can go on to develop the formal symptoms. And as I said, in some respects it's surprising that more people don't get PTSD. So, and everybody has a breaking point. I have a breaking point, you have a breaking point. Everybody has a breaking point. Let me just give you a personal experience and I'll show you, because in some respects, it can be argued that this is a normal reaction to such an abnormal event. So, I can think of working for the ambulance service. I went to an absolutely terrible car crash. And we had 4 teenagers dead. I can still see it, okay? Now after that, I had poor sleep for a few days. I had intrusive thoughts for a few days. I mulled over. I was distracted. I don't drink very much, so that wasn't a problem. But actually, when you go to something like that, it would actually not be human to think about them. Had I done the right thing? Was there anything else I could do? This was a car crash where 4 teenagers, the driver was drunk and they hit a tree. He was 17, they were 15, 16 and 17. It was terrible. But what protected me, if you like, from that. Although you can see I still see it, actually. I still see it. But what protected me was a range of things. Okay, I have an education whereby I know that that's normal. I knew that those symptoms I had were normal and they settled. Okay, so I had education and I understood about it. I'm reasonably fit. I brought my bike. I take exercise. So physical exercise is actually quite helpful as a protector. Positive outlook, okay, on life. Moral compass, I'm not sure what that means, but I was working for the ambulance service. This is doing good, as compared to perhaps if you were working somewhere and you didn't believe in what you were doing. Social support. Now, I've got a stable home life. Was when I left home, I'm sure it is still. But certainly within both the military and the emergency services, there's a huge camaraderie, actually, and that's a huge help. For those of you who are right, the use of black humour, that is just normal, okay? Sometimes people outside the NHS or health or the military don't necessarily understand that, but that's actually part of the way that we deal with this. So it's black humour. It's not in any way being disrespectful to patients or to their relatives, but it's the way that we have to deal with it. And also something about cognitive flexibility. So I knew that when having been to that terrible car crash, that if I got those symptoms, they would hopefully settle, which they did. But also I knew that if they persisted, firstly, soon my wife would know, oi, you're not right. But secondly, there's a good chance I would as well. And I think there's something about that in terms of, actually, if you think of the traumas that the police, the emergency services, people generally get, actually it's surprising that actually relatively few get post-traumatic stress disorder. But it's the vulnerabilities, which I think particularly Stephanie's going to come on to. If we look at the military, most of the soldiers who actually end up with post-traumatic stress disorder, if we track them back, they come from very difficult, disrupted childhoods, where often there's been domestic abuse. So actually they're quite vulnerable to start with, and then this jobs up. So the treatments are trauma-focused cognitive behaviour therapy, and I'll leave this to my sort of psychiatry, psychology colleagues to explain better than me. Eye movement desensitisation and reprocessing, they do work. Lots of research about new ones, particularly virtual reality. Interesting you said about MDMA, that's an amphetamine, okay? There's a big trial going on about the use of MDMA, actually. Very promising, in terms of being able to help people. So there's lots of research. There's certain things we know. It's better if it's treated early. And actually, I've given you a leaflet, which is the military one. So I've been sort of heavily involved, so if this is outside if you haven't got it, the military one. And the design of this military mental health service, if you haven't got it, it's outside. We've deliberately put in a 2 to 3 week performance indicator for the NHS providers, so that actually people can be assessed quickly. So it's 2 to 3 weeks, and then you get the treatments, which are CBT, MDR, particularly CBT for military, much quicker, because what we know is that accessing earlier is much better. And the reason that it's better is partly because the treatments are better, but actually what we're trying to do is intervene before people go downtown, before they don't go downtown and beat the bars up, they get a criminal conviction, they end up then not being able to get a job, have a Barney at home, all the rest of it. So actually intervening earlier is much, much better. Our problem is that the access in many cases to the psychological therapies is actually far too long. If I sit in Worcestershire as an NHS GP, it's sometimes 18 months, and that's just far too long. So in terms of this service, which is for military, we've now had about 6,700 referrals in, and again this is all in the public domain. I had the delights of the House Commons Defence Select Committee just before Christmas, so I promise you that was an interesting afternoon. But essentially that's outside it, and if you want any more information about that, I'm very happy to give that to you. My final case is another patient of mine. Again, we'll call her Joanne. And there's a key message here about the fact that, a bit like George, sometimes it's not just a one-off in terms of treatment. This is a school teacher. She was involved in a serious car crash 3 years ago, and although physically was uninjured, psychologically quite damaged, and it was the effects of actually being cut out of a car. So she was trapped, she was in fear of her life, and whilst the fire brigade were absolutely brilliant and cut her out, they literally sort of with the hydraulic cutters cut the roof off and then took her off into hospital with the ambulance service. She was in considerable distress. She actually accessed effective treatment via being paid for by the insurance company or the other driver. I saw her about 6 months ago. That was the first time I met her. And what had happened was that she'd been driving along the same road and saw somebody having virtually the identical car crash, with being cut out of the car as she was waiting. She was literally just seeing it being cut out, and of course it brought it all back. So she came in bits. She'd just thrown her job in because she couldn't manage the school. She was having interpersonal problems at home, and actually I said to her, but this is just normal. You know, what's happened is you've had a terrible event, and this is a normal reaction to a terrible event. And what you've seen has just brought it to the fore again. And actually what we did, again, she was lucky because of the fact that we were able to get further treatment paid for by Aviva or whichever was the insurance company. And actually when I saw her last month, she's now back at work, things are better at home. So actually accessing the treatment is really important. So what can we conclude about post-traumatic stress disorder, post-traumatic stress and trauma? Firstly, it's much more common than we would think, and Noel made that point. Secondly, I think in many cases we need better recognition of it. You know, certainly amongst us as general practitioners, and actually when I was looking at the numbers who actually are diagnosed within hospital services with PTSD, I just think they're far, far too low. Often they're diagnosed with depression or anxiety or adjustment disorders. And actually I do wonder whether or not that's actually because of the access to psychology, because if you make a diagnosis of PTSD, it leads you down a certain route. So we need better and earlier treatment. I talked about my local NHS patch. The problem is they're brilliant people, but there just aren't enough of them. And we've got a waiting list of about 18 months, and that's just really unacceptable for the reasons which I've explained. The other point is, as I say, we all have our breaking point. We have a number of things which allow us to cope, and the analogy I often use is a bucket. So if you imagine your resilience is your bucket, and how big your bucket is, and then the stress is the amount of water that bucket can take. So that if you've got a big stressor, it will overflow, and then you end up in problems. Similarly, if you've got a small bucket, whereby you have less resilience, you can have a smaller amount of water that comes in and it will overflow the same. So it's a dynamic between the two. And one of the reasons why people actually don't get things, even sometimes with terrible stressors, their bucket is really quite big. And that's quite a useful analogy to think about in terms of how we manage. And I think the final thing is that when it comes to this isn't the patient's fault. Yes, they may be less or more resilient, but it's actually something about the stressors, the amount of water that's actually going into the bucket. So it's a dynamic part, and I think that our role as clinicians is to recognise and treat where you can help us as actually as writers, as being able to dispel some of the myths about this, and actually to help us actually identify people in order that they can get the most appropriate treatment.
Thank you very much. As as writers, we're always needing case studies and to illustrate the diagnosis, the difficulties people face and the different types of PTSD and other trauma through case studies is extraordinarily helpful. Thank you. Now we're going to hear from Dr. Angela Kennedy, who is working full-time in mental health processing and people with therapies and providing therapy. So we've got two specific types I know you're going to talk about, but others as well, I think. So thank you.
Hello, so I'm a psychologist by background. I've worked in the NHS my whole career. I'm probably very institutionalised, I can tell you that from the start. I'm based in the north of England and I've worked in the NHS since 1990 and seen a lot of ways of managing trauma come and go over that time, and I've got just a short amount of time really to create a bit of a story about what I think is the current way that we need to start thinking about trauma in our systems, in our healthcare systems, and a little bit about how that has impacted on me very personally. So the first thing I want to say is that the way that we talk about trauma in our services has changed, partly because I think it faces us with a very dark reality about our humanity. And I think it's easier to think about psychiatric problems and mental health problems and suicidality as being disconnected from our lives. For me, it isn't. It is rooted in the way we live our lives and the communities that we live in. And so for me, thinking about trauma requires us to face the darkest aspects of who we are as people. That's the challenge, and we don't like to do that. We like to hold on to something as a sense of goodness, but actually we have a dark side, and this is often our dark side. So I'm using trauma in a very wide sense of the word. So if you look at Oxford English Dictionary, it would say trauma happens after a threat to life and limb. In my experience though, people get traumatised as a result of a lot more than that, and that's partly because we are not simply reptiles where threats to life and limb are what motivate us. As social animals, it's often our attachments and the betrayal within those attachments that create a sense of trauma in us. So yes, events which provoke fear and pain can be traumatising, but also events which provoke loss, often of people, but not necessarily of people. So homelessness, I would say, is a potentially very traumatising experience for people. I think events that exclude us from others, so certainly if you have to leave your country as a refugee, if you are bullied and ostracised at school, sent to Coventry, these things have a very profound impact on us. Situations that challenge our reality, and we need to know what our reality is in order to function, and things like gaslighting, where you have your reality challenged, really undermines the foundations of what we need in order to function well in the world. And a lot of trauma, certainly in my experience in working with people with complex mental health difficulties, comes from relationships that inflict harm on other people. So domestic violence situations, sexual abuse, physical abuse, that kind of thing. But also something that's very pernicious, an absence of care or neglect. We often hone in on those very high risk kind of issues that we think are significant for somebody, when actually the absence, not being worthy of any care, often has a much more profound impact, not just on somebody's resilience, but on their own sense of self. And as has already been mentioned, witnessing any of these also can have a profound impact on our emotional well-being and how we see the world. So when I'm talking about what I know about trauma, I'm talking about these kinds of things and the meaning that we place on these things and the way that it helps us create a sense of safety in the world. So, as well as those events, we have to think about the positive events that kind of counteract this. And what we know is that the closer the relationship was with the person who hurt you, the more likely you are to be traumatized by it. So in particular, if it's a parent who you are dependent on and they abuse you, that's much more potentially damaging. We know that how long it goes on for is also another risk factor. And we know that the earlier it starts in your life creates more risk. We know that the severity of the act and the risk, so when we're talking about sexual abuse, actual penetration is a lot more damaging than something that is simply touching, but that's not, a lot of this is about the meaning and the context in which this takes place. One of the key things that's been mentioned is the support that you have at the time. Did you have anyone safe enough to tell what was happening? And did they react well? Because if they did, you might not become traumatized by it, no matter how horrific that event was that you experienced. And also having adequate information. Quite often traumatized people just say their very narrow experience. And being able to know what the whole of that experience was and how things interacted and all of the factors that influenced that event really helps people. And that's certainly when you're processing trauma, it's one of the key things we look for. What missing bits of information do you need in order to be able to create a different kind of meaning? So I guess like this field of grapes, when we grow up, the context in which we grow up influences the kind of grape or person that we become. It's not just your genes and the particular variety that you plant. It's the sunshine that you have, it's the rain that you have, it's the soil that you grow in, and it's when you're harvested. These things impact on us just as much as that grape. So trauma for me needs to be understood in its context. So mental health problems need to be understood in a context. People who come for help are a product of the context in which they have grown up and experienced their lives. So there's an idea that's receiving a lot of popular attention called ACEs. And you can have an ACE score out of 10 based on the number of experiences that you had as a child that you can tick from this list. And you can see it's fairly wide-ranging. And maybe you can, looking at that list, think, roughly tot up what your ACE score might be. So these are only things that are happening as a childhood, remember. My ACE score happens to be fairly low. I think that instead of creating difficulties for me, I think it made me motivated to work with people. I felt like I got away with things lightly, and that made me stronger, gave me a toughness, gave me an empathy for people. And it certainly didn't give me a them and us attitude towards the people I was working with. I thought, that could have been me there. I grew up in East Gateshead. And this photograph was by a fantastic photographer. This was the era in which I grew up. That was Newcastle in the early 1980s. That's the reality. You can see that simply a checklist does not do this justice. So let's just look very briefly at how these ACEs pan out in terms of population risk. So in terms of adult alcoholism, you can see that the more ACEs you have, the more likely you are to have adult problems with dependency on substances. And yet how often do our substance misuse services include attention to trauma? They don't screen, they don't treat, and they're not integrated with trauma services. There was a prospective arm of the original ACE study, and that found that people experiencing 6 or more categories of adverse life experiences shortens an individual's life expectancy by 20 years. I'm just going to let that hang there. 20 years. What else would we ignore in our society if it shortened our life expectancy by 20 years? And yet somehow we as a society struggle to see the blatant evidence that is there in our face. We don't like to turn and face this, that this is the reality for people. If we don't do something, this is the impact that inequality has. And my own region has some of the shortest life expectancy in the country. It also underlines suicide attempts. How often do you hear about this in our public health campaigns around suicide prevention? So you can see exactly the same pattern. The more ACEs you have, the more likely you are to try and take your own life as an adult. So your risk is between 12 and 20 times greater if you have an ACE score of 4 or more. We're not talking about just a slightly increased risk. Massive, massive fold increase in suicidality. So I've worked for a long time with people who in kind of specialist services, for those where generally services are struggling to manage them and struggling to maintain hope, and certainly kind of recovery is not acknowledged. So spent a lot of time working with people with schizophrenia, so-called personality disorders, although I'm of that view that if we shouldn't be calling people personality disordered if they have complex problem. I think it's the biggest insult we can serve those people. But this is a really interesting, very, very large-scale study, thousands of people on this in this study. So people who have experienced 3 kinds of abuse have an 18-fold higher risk of psychosis. So that psychiatric illness that we think of and always talk about as the icon of biology has an increased risk of 18-fold. Those experiencing 5 ACEs, 193 times more likely to become psychotic. There may well be people in our services who have psychosis or schizophrenia who have not got trauma histories, but I haven't seen them, and I've worked there a long time. So Felitti, who did the original ACE studies, he says that once we start to pay attention to this could be one of the major public health advances of our time. Because even simply asking the question in the context of a validating relationship, wow, look how many doctor's visits it reduced, including emergency room visits. Isn't that amazing? The opportunity to have this experience validated can mean that people can somehow feel healthier, so they don't feel the need to go to the doctor. Astonishing. So we basically have 3 types of emotion systems. We have a threat system, and that's the one that our services pay most attention to. But we have 2 others. We have a drive system that's governed by different neurochemicals, and like you're saying, amphetamines, very empowering, it's goal orientated. In terms of, you know, if you won the lottery, that's the system that would be activated. It's that woohoo, very short-lived feeling. You always need the next fix for that feeling. We have another one that we almost pay no attention to in our communities, but actually it's the one where our resilience comes from. We have something called a soothing system, where it's about feeling socially safe. This system creates resilience, so that if you have a good soothing system, good social connectedness, and a capacity to feel calm and content, it moderates the impact of threat. So you have less depression, less PTSD. So when services, it's not just about dealing with the threat, it's also about how do we build up people's resilience to moderate the threat. Now, threat dominates when you are traumatized. So you get lots of threat defenses, lots of motivations that are pulled on, that are not about goal seeking, that are not about connectedness. They're about revenge, they're about grievance, they're about anger, they're about splitting off. And so what happens with the other systems is that also they kind of diminish. So you become very demotivated, or you also feel very alone and isolated. And these are two drawings that somebody I worked with used, and I think they describe very well the impact on people's sense of self when they've been very chronically traumatized. So this person, you can see she's describing a lot of self-states that she presents to the world that serve a really good function of her hiding her traumatized self away. And that works up to a point. But this is constantly suffering, constantly throwing up symptoms that she can't manage, that these fronts can't really tolerate very well. And then when things all go terribly wrong, she has a florid psychotic episode where she feels extremely fragmented. And that actually you can see, you know, so many times there's that kind of doll, Russian doll figure in the middle. Then it's no longer fully healed. It's a fragmented, loosely bound self that's left. And also, you know, we talk a lot about cognitions and beliefs in PTSD, and they are certainly important. But when you're talking about trauma that is early, often people are not thinking, or their thinking is secondary. Those beliefs are secondary. Our early memories, very few of you will have memories before the age of 3 or 5, and that's because autobiographical memory systems are not online at that point. So what you have when you've had very early traumas in particular is you have sense perceptions. It's held in the body as implicit memory. It's held as patterns of attachment. So this was the best description that somebody I worked with could come up with in terms of how their PTSD felt. It wasn't in terms of ideas or memories or beliefs. It was, there is something disgusting on my leg and it's coming up to get me, with an absolute terror associated with this thing that was not part of her. So what are the implications then of trauma that is like this? Well, first of all, traditionally our services, they will diagnose somebody coming for help, and that diagnosis will be something inside of them. So their symptoms are categorised and it's seen as something is wrong with them. And unfortunately though, that means that if you're coming to services, you have two choices. You either comply with that and then you're a good patient, or you defy that and then you're a bad patient and people don't want to help you. But with complex trauma, where you are abused in your own home and you can't fight and there's nowhere to run to, what you get is you learn to be hypervigilant to what other people want of you, and you comply and you please them. So for me, a compliant patient is usually in a threat state, and they've learned to do that very well. So in services, we need to empower people to sometimes disagree with us. And I worry that this model partly expects people to comply with this idea that there is something wrong with them. So a trauma-informed system thinks about people's problems slightly differently. It sees their symptoms as a reaction to the context in which they're in the same way that that grape is the virtue of its context and the weather that has grown it. So in a trauma-informed mental health system, we wouldn't be labelling the problem as within the person. We'd be labelling the problem as outside of the person, with them as reacting to it. So I'm suffering and reacting to what happened to me. Now you can see immediately so much more empowering and a lot less shaming There's a lot of stigma about mental health problems, and people, it's not just stigma from other people, but people feel ashamed of themselves. And this idea that we have that there's something wrong with you, that you haven't managed it well, you know, that people feel ashamed about that, and shame is one of the most pernicious problems we face when we think about recovery from mental health difficulties and trauma. So our systems in mental health need to take a much more multifaceted view. So quite often we think about, you know, that the cognitions in relation to what's in the middle there, you know, your relationship with yourself, whether you feel ashamed of yourself, whether you're critical of yourself, and how integrated your sense of self is. But there's also the neurobiology to take into account, and the way that this plays out in terms of our symptoms. And certainly, you know, those figures that I showed you earlier, they apply to our acute problems, they apply to diabetes, they apply to cancer, they particularly apply to medically unexplained symptoms. That's a big, costly issue in our acute hospitals. So we need to pay attention to the body and how traumatized people's bodies are. We need to pay attention to the society. These problems are playing out in our society in terms of, well, do we house people with psychiatric problems? Do we see people who are born from intergenerational traumas? Do we label them as the problem? And where are the limits of our compassion? Because sometimes we can be very judgmental of people like this. And also, trauma impacts on our relationships. And so healing from trauma requires a relational stance. It happens within our relationships where we feel safe and we can trust, and that's really hard to do when you have been abused chronically. So we need systems in our mental health services that pay attention to all of this. And so quite often, certainly NICE thinks about our services as, you know, you have a prescriptive and linear view through services that's evidence-based, and you can do this, that and the other in a kind of a linear manner. The difficulty is a lot of the people who come for help have multiple comorbidities, as you alluded to. And so what we need are pathways for trauma that means that it clips onto any diagnostic pathway. This is an issue not just for people with PTSD, it's an issue for people with depression, it's an issue for people who have psychosis and schizophrenia. All of our mental health problems are influenced by the lives in which people come to. So we need to think about our pathways that incorporate ideas of trauma, and certainly the trials for NICE didn't, because your populations by default, but to have an RCT, need to be very clearly delineated. That's not the real world. So you need to think about recovery from trauma as being like over time, not that you do the trauma processing, which is the red bits, as a one-off and then you're fixed. It's clustered in the middle of someone's recovery journey, but you might need to revisit things a few times. And these are the kinds of things that really help us to process trauma in those middle bits, those so-called hotspots. So we need an orientation of the mind and the body to the present. In trauma, you're often caught up in the past, whether that be in a flashback or in relationships, as if it's going to happen again. You need dual attention between trauma and the present moment. You need to be able to experience the emotion without avoidance, which in PTSD is really hard. Wow, you know how hard it is to revisit that horror, and certainly as a therapist, when you've got somebody vomiting again in the room, it's horrific. Learn how to relate through this, through the relationship, and make meaning of the event. And this was a really good blog that you can find online of somebody who is a voice hearer, who found a different way of both identifying her demons from the past, which she heard as voices, which were her link to her abuser, and healing them. And you can see the process of transformation. That's the same voice, the same picture of the abuser, but it's changed over time. Healing happens through many modalities. And this is a sneak peek at a real-world framework for trauma-informed innovation that I've been working on with the Academic Health Sciences Network and the Clinical Network, which is a branch of NHS England. And this is learned from lots of good practice examples around the country, and these are the kinds of things that services need to be doing in order to be moving towards this trauma-informed kind of culture change. So I'd like to talk a little bit about EMDR, and this is how I would describe EMDR. It's a branded technique that uses bilateral stimulation of vision. So quite often you follow somebody's fingers while you hold in mind the memory. But it can also be sound or touch. And what it does is it harnesses the brain's natural integrative properties, because it's joining up different bits of the brain. So thoughts, feelings, memories with the present day, joining all of those up. And once it's integrated, you can be more grounded in the present. So I'm going to talk a little bit about, just a tiny bit, about my own PTSD. That's fairly recent. And it wasn't vicarious PTSD. It was PTSD related to what was deemed a serious threat to my life. But I can tell you now, it wasn't a threat to my life that I found traumatising. It was the organisational response to it. Now, I've worked in NHS for a very long time. I've dealt with lots of high risk, you know, the kind of things that would make your eyes water. I thought I was tough, I thought I'd be okay. I had loads of, you know, I'm the go-to person when people get stuck with people. I still ended up with PTSD. And as I said before, you know, these are the kind of factors that influence whether you get PTSD. And these are the kinds of things that were impacting on me in my bucket at the time that made it really difficult. It wasn't just the actual risk. And certainly I just wanted to get rid of this experience. I wanted it to be okay, I wanted to move on, but my reaction to it was beyond my control. I had terrible trouble sleeping, and I would ruminate for endless hours over what was happening, and I didn't understand what was happening, and just awful. My concentration was rubbish, the tea was always burnt, and my mood was awful. I scored pretty high for a while on depression scales. And so I have trained in many different therapeutic modalities over the years, but I went to an EMDR therapist as my treatment of choice. And, you know, but a fairly idiosyncratic EMDR therapist who I knew would not necessarily just stick to protocol, but would incorporate all those attachment things and all of the resilience and the attachment resources that I knew I needed to heal from what I saw as a betrayal. So these are the kinds of things we worked on. I'm at risk, I'm betrayed, I am under no value. Kinds of images that you end up, that you know you can use. Kind of, I pictured this kind of golden room that was very fluid. Other staff who knew my value. My dog, perfect. And also creativity. So I do have an art practices, and this was, and I have to say these are not good art that I did during this time. In fact, it was really poor, but they helped. The creative process helped my journey. And this was about my insomnia, and it also, I was writing a lot of poetry at the time about the experience, and it has a couple of lines about my insomnia kind of woven into that image. But the outcome is, I now have a profoundly different knowledge about trauma than I had previously. Very different. I know how hard it is, even with all my own skills, to put them into practice and recover from a traumatizing event. It's really hard. And so what does it mean to be healed? You know, is there an actual cure? I think for some people, sometimes, if it's a single event, but for others, it's a constant process of manage it and thinking you've got there, and then you'll be re-triggered or something else will happen. There's the idea of functional cure where, okay, you might still have the symptoms, but you can work around it, and I think a lot of people with PTSD have to do that in the end. And there is also an idea of post-traumatic growth, and I think for me, having seen and experienced trauma from the inside out now, wow, what a difference that I think will make to my practice. There's also different ways it can be framed. So is this damage? Yes, I do feel damaged actually. Is that me just being critical because I'm not quite out the other side? Possibly, don't know. This thing about it being your choice, you know, how you deal with it. You hear lots of positive stuff on Twitter. Well, it's your choice about how you react to things. I can tell you, this was no choice. I knew what I would have chosen, and I would not have chosen PTSD. No choice. Do I have some vulnerability? Well, yes, I have. My score pretty low. But when I've been doing the process, and it's not that vulnerability that's been coming up. We all have our breaking point, and you never know when it's going to come. So, I think these are battle scars. And that's how I see my PTSD. It's a battle scar. It's a sign of survival, and one of the poems I wrote about that actually is one of the ones that I'm most happy about. It's not, it creates an opportunity for empathy and compassion, and also an awakening to what trauma means in the lives of people with mental health problems. And this Judith Herman, who's written a lot about trauma and recovery, you know, she talks about how this idea of how trauma, we want to banish them from consciousness, and actually, you know, being faced with them, whether yourself personally or in our systems or in our societies, in our news, is what we need to do. These are unspeakable secrets, and we need to join things up. For me, integration is healing. We need to hear stories, not just of abuse, we hear lots of them. Not just of mental health, we hear lots of them. How often do we hear stories in the media that join up those two realities and say, actually, there is something going on here. These stories are leading to our mental health problems. So, finally, what stories can you tell from your lives that might hook into some motivation about what you can say about trauma? What about this value of community safeness that creates a community resilience and buffers people? And what stories can you tell around action on trauma and mental health, and why that's important now for us? And that's it from me. That's me. I'm also on Twitter. Thank you.
Questions there for society, for politicians, for everybody, and also some very intimate ways of writing about therapies and healing. I won't say any more because we have questions and answers in a minute. But first we are going to hear from Dr. Stephanie Lewis about her work as a psychiatrist in this area. Thank you.
Thank you very much. So thanks very much for inviting me here today. I'm really pleased to be here to discuss my research on trauma and PTSD in young people. I'm a psychiatrist, and I work and research young people who've been exposed to trauma and who develop PTSD. And when I tell people this, lots of people are often surprised and tell me they didn't realise that young people could be exposed to trauma and develop PTSD. And it's certainly true that we most commonly think of trauma and PTSD in adults, which might be because PTSD was first described in adults, particularly in soldiers, and there's been a great deal of research in that area. But we know from our clinical practice and research that young people also experience trauma and PTSD. In fact, young people experience the highest rates of trauma. This plot shows rates of a range of different trauma types indicated by these different lines. And these all peak in late adolescence. And young people might be particularly vulnerable to the adverse effects of trauma. They're undergoing important neurobiological, emotional and social development. This figure shows that brain development, shown by changes in colour, continues to past 20 years old. And traumatic experiences might disrupt this development, which could have long-lasting and detrimental effects on mental health. So for these reasons, it's really important to consider trauma and PTSD in young people. So I thought I'd start by clarifying what I mean by trauma and PTSD. I'm glad that some of the speakers earlier have touched on this. So I'll briefly just go through this again, just so that you know exactly what I'm referring to when I talk about my research. So I use the clinical definition of trauma, for example, as in the Diagnostic and Statistical Manual of Mental Disorders, the DSM, which describes trauma, defines trauma as an event that involves exposure to actual or threatened death, serious injury, or sexual violation. So as we've heard, this can cover a wide range of events, from accidents and illness to violence and abuse. And these experiences can be either directly experienced, witnessed, learned about happening to a loved one, or experienced by enduring first-hand, repeated or extreme exposure to details of the event, for example, as might occur for people living in war zones. And immediately after a trauma, most people experience some psychological symptoms, as we've heard earlier today. They might feel very upset, feel on edge, have memories of what happened. But these symptoms usually resolve in days to weeks. However, for some, symptoms might be longer lasting and might interfere with their daily lives, which could indicate the development of a mental health disorder. And post-traumatic stress disorder, PTSD, is a unique mental health disorder in that trauma is included in its diagnostic criteria. So you have to have been exposed to a trauma to develop PTSD. And therefore, PTSD is the disorder that's most often thought about when we think about mental health disorders that are related to trauma. And PTSD is characterised by 4 sets of symptoms that we've heard about today. So firstly, re-experiencing the trauma as distressing memories, flashbacks or nightmares. Secondly, avoiding reminders of the trauma, such as people, places, thoughts and feelings. Third, having negative cognitions and mood after the trauma, so having thoughts of guilt and feelings of isolation and detachment. And finally, having increased arousal, which can lead to irritability and difficulty concentrating and sleeping. And as we've had, to meet criteria for PTSD, these symptoms need to have been present for more than a month and to cause substantial distress and impairment. And there's been very little research on the mental health burden of trauma in young people, despite the importance of this topic that I mentioned earlier. And so, in order to improve our understanding of this topic, I work with my colleagues at the Institute of Psychiatry, Psychology and Neuroscience to carry out the first study of trauma and PTSD in British young people. And this study was published recently in the Lancet Psychiatry, and so today I'll briefly discuss some of our findings and their implications. And I'll focus on answering these 3 questions. Firstly, how common are trauma exposure and PTSD in British young people? Then, what difficulties do trauma-exposed young people experience? And finally, do affected young people access health services? To answer these questions, we interviewed participants in the e-risk study. So this is a population representative sample, a large sample of over 2,000 children who were born in England and Wales in 1994 and 1995. And we followed them up every few years throughout their childhood, and most recently at age 18. And it was at this age 18 assessment where we comprehensively assessed their mental health, including assessing whether they'd been exposed to trauma and whether they developed PTSD in their lifetime. And so we use this information to consider how common trauma and PTSD are in our sample of British young people. And we found that about nearly a third had reported trauma exposure, and 7.8% had developed PTSD by age 18. So that's about 1 in 4 of those exposed to trauma. And so these findings provide and highlight the extent of trauma and PTSD in British young people for the first time. We then looked at the type of trauma that young people described as their most upsetting trauma, and found that this was most commonly network events, shown in yellow. And this refers to types of trauma that involve learning about the sudden death, injury, or sexual assault of a close member of their social network. So, for example, learning about the death of a parent. And this was reported by about a quarter of trauma-exposed young people. The next most common trauma types were direct interpersonal assault or threats, that can be physical or sexual, and that's shown in red, and direct accidents or illness, shown in pink, and they were both described by about a fifth of trauma-exposed young people. However, in participants with PTSD, by far the most common trauma type was direct interpersonal assault or threats, which was reported by about half of those with PTSD. So these findings indicate that direct interpersonal traumas account for a disproportionately high number of PTSD cases and are associated with a very high risk of PTSD. So these findings that I've discussed so far reveal that trauma and PTSD are common in British young people. And this indicates the need to plan and provide adequate resources to health services to meet the needs of young people with PTSD in our communities. Our finding that young people exposed to direct interpersonal traumas have the highest risk indicates the need for further research to understand and address why these young people have this high risk. So we next considered broader difficulties that trauma-exposed young people might experience. We studied whether they developed a range of other mental health problems in the past year. And this plot shows the rate of these conditions in the overall sample, just for comparison. And here in blue are the rates of these disorders in trauma-exposed young people. So you can see that the most common conditions experienced by trauma-exposed young people were depression, experienced by 29%, conduct disorder, experienced by 23%, and alcohol dependence, experienced by 16%. And importantly, the rates of all these wide range of different disorders was about twice as high in young people who'd been exposed to trauma compared to those who hadn't been exposed to trauma. Next, we considered the rates of these conditions in young people with PTSD. And we found really high rates. So young people who'd had PTSD, of young people who had PTSD, over half of them developed depression, and about a quarter developed generalised anxiety disorder, conduct disorder, or alcohol dependence. And in fact, 3/4 developed any of these disorders. And we found that of those, the rates of having any of these disorders were over 4 times higher in young people with PTSD compared to those without PTSD. So these findings demonstrate that trauma-exposed young people, particularly those with PTSD, have high rates of this very broad range of other mental health conditions. We next considered whether these young people had any difficulty getting on with their daily lives, which we call impairments, and whether they had any risk of harm. So we studied impairment by assessing whether they were not in education, employment or training, NEET, at age 18. We studied risk of harm to themselves by assessing whether they had self-harmed or attempted suicide since age 12. And we studied risk of harm to others by assessing whether they'd committed a violent offence since age 10. And in trauma-exposed participants, we found that 17% were not in education, employment or training, 25% had self-harmed, 8% had attempted suicide, and 7% had committed a violent offence. And these rates are all significantly higher in trauma-exposed young people than in young people who hadn't been exposed to trauma. And finally, we looked at the rates of these events in young people with PTSD, and again found very high rates. So a quarter were not in education, employment or training, really large number. Half had self-harmed, a fifth had attempted suicide, and just over an eighth had committed a violent offence. And again, the rates of these conditions in young people with PTSD were significantly and substantially higher than in those who didn't have PTSD. And these findings indicate that trauma-exposed young people, and particularly those with PTSD, have very high substantial impairment and risk of harm. So these findings provide the most comprehensive description of difficulties that trauma-exposed young people experience that there's been to date. And although not all trauma-exposed young people develop difficulties, we found that on average, trauma-exposed young people do experience high rates of any mental illness, not just PTSD, and they also experience high rates of impairment and risk. And this indicates that trauma-exposed young people who are seen by health professionals need a comprehensive assessment to really identify these potentially broad difficulties. And we found that young people with PTSD typically have complex presentations, so most have another mental health condition, and many experience substantial impairment and harm themselves. And these complex presentations can be difficult to recognise because some problems might overshadow other problems, making them difficult to see. And these complex presentations can be very challenging to treat. So the fact that they're typical indicates that mental health professionals need to build expertise in assessing and treating these typically complex presentations in young people that come to our services. So finally, we considered whether trauma-exposed young people and those with PTSD access health services. So we asked our young people about their health service use for mental health problems in the past year. And in trauma-exposed participants, despite their high health burden that we've just seen, we found that very few had access to health services. Only 1 in 5 had seen any health professional, and 1 in 10 had seen a mental health specialist, so a psychiatrist or a psychologist, and within that we included counsellors and psychotherapists and nurses as well. And in young people with PTSD, despite them having a diagnosable and treatable mental health condition, which we've seen often comes with a very high mental health burden, we found that few had access to health services. So only just over a third had seen any any health professional rather, and just 1 in 5 had seen a mental health professional. So these findings indicate that young people with trauma-related disorders often don't receive treatment from health professionals. And this is really troubling because we know from previous research that mental health specialists can provide effective treatments for PTSD and other trauma-related disorders. And we also know that without this treatment, a large proportion of young people with PTSD have persistent symptoms. It's not clear why so few young people with PTSD access services. It's likely that several factors contribute, including factors that prevent young people and their families from seeking help, such as stigma and shame that we've heard about earlier today, as well as barriers within health services that prevent young people from accessing appropriate specialist care, for example, a lack of resources. And so there's a real need to identify and address these barriers to care so that we can provide more effective treatment to more young people with PTSD. And this might include not only encouraging more young people and their families to seek help, but also ensuring that health services are adequately resourced and adequately trained to meet the needs of these young people. And if we can provide effective treatments for these young people, we'll not only reduce the mental health burden in childhood, but will prevent these mental health problems continuing into adulthood. So I'd like to thank my collaborators, the ERIS study participants and families, and my funders, and thank you all very much for listening.
Ready for questions? Would anybody like to? Sally?
Hello, my name is Sally Brown. I'm a journalist and I'm also a therapist. I have a question for Noel. You said you had all the trauma treatments. I'm curious, what were they? Which did you rate? And which do you actually use now in your practice?
Sure. I didn't have EMDR. They hadn't been invented.
Okay.
I'm that old. So CBT. I had integrative approaches. I had psychodynamic approaches, or relational, I think, would be a better description, and behavioural approaches. So a whole range of stuff that took 20 plus years really. So it wasn't something that happened overnight, and and it was something, my experiences, I came in and out until I was able to cope with it. I did have one period of time when I saw a therapist for 5 years, but it wasn't continuous over time. In terms of what do I rate, it was different. The journey isn't simplistic, and I didn't, and nobody develops in a simplistic manner. My experience is you tackle the work that you cope with at that time. So the CBT was undoubtedly amazing, and a revelation and a breakthrough. Learning that I could have some power of my thinking was really interesting to learn, because I just thought it was. Learning how to look at evidence for and against things. Very simple stuff that I had no capacity to do, which I think most people just do because they learn it growing up, but I had no idea about doing that. And affect regulation, sort of learning how to recognise symptoms that I was terrified. Oh, I'm terrified, I better do something about that. Learning the tools of relaxing and breathing. I think mindfulness meditation was extraordinary. No, I don't think it was, I know it was. It was extraordinary. I was having a panic attack in Homerton A&E, and I used to be a regular patient. So I had my own day in A&E. And they had me hooked up to the heart machine, as they did, because they were very lovely people. Oh, well, hello. I think I'm going to die, but I know it's just a panic attack. And they sort of put me on the machine to sort of let me calm down. And a nurse came in and said, your problem is not. I was like immediately on edge, about to be attacked. She said, you just don't know how to breathe. And she just sat down with me and taught me what I now know as mindfulness, which is a simple breathing technique. So that was very good. The interpersonal stuff was crucial in terms of getting back into meaning and connection with people, and as was described, the drive, motivation, because life's not much fun if you just have all your symptoms taken away. And there's not really much point in doing stuff, so there has to be something else on offer, and so all of that stuff. The arts were fundamental, and in terms of learning that life could be fun and creative. Relationship stuff, I mean a whole bunch of stuff really. What wasn't useful was any sort of regressive techniques. It just didn't help at all. I wasn't repressed, quite the opposite. So
Thank you.
right.
But Mary Claire, did I see your hand up?
It was, thank you, Hannah, you're absolutely wonderful. My mind's buzzing with everything. Jonathan, can you just say a bit more about CBT when it's trauma focused? What does it actually mean? Does it just mean...
You're probably the better person to answer.
So trauma focused CBT is a bit different from CBT as it usually is, and trauma focused CBT focus specifically on the re-exposing somebody to the trauma memory, so that you re-evaluate the meaning of that event and the fears that were generated at the time, and through a process of what's usually desensitization and what's called cognitive restructuring, the distress around that event is lessened.
One of the issues about that, I said, is the DNA rate, because sometimes the therapy is difficult.
It's brutal.
And so what you're trying to do, so there's something for us as the NHS, so there's quite often a thing of, your DNA wants and you're off the books. So that one of the things that we've been trying to do, certainly, when we've been looking at the sort of military, and again this is because there are specific contracts for this, is actually putting in that there needs to be a really strong proactive approach and follow-up for people who do not attend, so that actually you can actually encourage people to attend. And one of the things we've been looking at is more a sort of case management side. Now there's case management in terms of the NHS services, but actually one of the most useful is case management from the individual. So if this was my patient, then I'm a friend, and I'll be going, look, do you remember you're seeing Angela as your therapist a week on Tuesday? I can take you. And actually reducing some of those barriers And actually, that's one of the things certainly we will often support. And if we get third sector charities, people like this, not that they're providing treatment, that's what we do. But what they can do is that they can act as facilitators, so that actually they can help and facilitate people to attend in order to get treatment, because the treatment is difficult, which is the reason why the DNA rate sometimes is very high.
Can I talk about that a little bit as well? We were talking earlier on about some experiences in South London and mental health services in South London, and sort of developing these key worker type relationships, which I think are crucial, and something we're passionate about. Is part of what we do in my work is develop. In mainstream mental health services, they call it assertive outreach, but it's only given to people who are deemed at very high risk. And I actually think it should be pretty standard practice across the board in all mental health issues, apart from the ones that highly, that there is a big safety net for. But in terms of trauma-informed work, I think people just don't understand that asking people to really experience stuff that they've learned to run away from as fast as possible is a big ask, and there's a lot of support needed around. I suppose it's the social network stuff, and if you put this network around people, whether it's people you pay to do that, or it's peer-to-peer groups, or whatever it is, the chances of you getting people into treatment and staying through treatment is significantly higher. We've known this for a long time, and so linking into these other services and other groups and encouraging them. We've begun to do it. It's happening in some areas, such as they're called recovery colleges, and so we're beginning to see that. But I think this could be very exciting developments. All of that stuff.
That's we need to know about all these things. I'm going to take 2 more questions because Saka is waiting, and we can continue talking outside. And Jane.
I've not heard of these ACE scores before. Are they widely accepted? Are they new? And do you all agree that they are useful measurements, ways of measuring?
Wales has a national public health programme based around ACEs, and Scotland has a national commitment to be the first ACE-informed nation. So they are doing cross-sector training awareness around ACEs. I think they're a useful public health tool, but when you're talking about adults, there's lots of adults trauma. It doesn't include, so it wouldn't include combat trauma, for example. It's simplistic, and when it comes to the individual, it misses the nuances around the meaning and the support and who did those things and how long it went on for. So as a public health tool, yes. As an individual screening tool, no, and I worry about it being used as a bit of an assessment tool in services for individuals, because that was not what it was designed for.
So I went to a thing with Public Health England last week actually, yeah. And I think everybody would recognise the importance of adverse child experiences having an impact. But what the experts would worry about is counting them up in order to then say you've got an ACE score of 6.
That's what I thought you suggested.
So I think the academic, which is what the Americans do, it's come from the States. So I think that intuitively it seems right. If you look at, I talked about one of my patients, and if you looked at her ACE score, it would be high. So it's not surprising. And again, that lady would come across all 3 of us actually. But I don't think anybody would want to say because you have an ACE score of 6 that it's much more complex, and that's it's that complex interrelationship, and then also what happens to you subsequently.
It's also about the role of hope. As well, diagnosing people with loads of stuff that weighs them down is a great, from my experience, I've got an ACE score of 8, but I'm all right. And there's other things going on in people's lives, and those things are equally as important.
Yeah.
And they need to be brought into it, because when you're in treatment with people, I think the ACE scores are useful, are useful indicators of services at service levels, and in terms of commissioning services, they're really good evidence for saying, we should have more stuff there and more stuff there. But in terms of individuals, in terms of people, we're looking at healing and resilience and drive, as well as symptom reduction.
And that's what the research shows as well. So we know if we look at people in groups that we see these associations that we saw in your talk earlier, but we don't know, it's not research yet telling us whether these ACE scores can be used to predict individuals' risk, and that's a really important difference.
Yes, Sally. Sally too.
Yeah, sorry, Sally Beck. Angela, I was reading the ACEs that you had listed, and the one that didn't seem to be there was the death of a parent.
Yeah, it's not on. There are other things that aren't on.
Why is that? That's really interesting.
You need to ask the originator of that. I mean, there's lots of things in that I think I would have issue with. So, if, for example, the population I would work with, they would not class themselves as having been physically abused because the violence is so endemic. That's just, they wouldn't class it as abuse. But also the domestic violence one is gender bias, so the exact wording on the form is it can only happen from a male to a female. It looks like on the form. So yes, I think that's one of the issues with it. Lots of things. Bullying's not really.
I did. All right, one more, and then we must go. Paul.
Thanks for all your talks. They were fascinating. Just mainly for something question. Something like the Manchester bombing, where a lot of people were there in one place. A lot of young people, I would say, and most of them would have been offered counselling afterwards, and then the referral to a clinical psychologist. But I was wondering if younger people, would that any sort of PTSD manifest itself in the months or the year after that, or would it be a longer process where they would need help later on?
Yeah, so it can vary for different individuals. So we know that for most people who would have been exposed to that traumatic event in Manchester, they probably would have had some symptoms. And we know that that's true for almost anyone that experiences a trauma. And that's, I guess, what we would class as a usual reaction, and those symptoms usually resolve in days to weeks. But it's for those young people and other people, I say young people because I'm used to talking about young people, but for those people whose symptoms continue longer lasting and impair their ability to get on with their lives and are really distressing, that it's then that it's important for them to get assessed and to see if they are experiencing a mental health disorder that could be treated.
So Manchester is a bus ride away for us, so we had lots of referrals from our patch and some deaths as well from our area, and the referrals are still coming through now.
Because it can, because I guess symptoms might be quite confusing as well, and young people and all people who experience these symptoms might take some time to really sort of, I guess, understand them and to realise that they want to seek help or that they need to seek help. So it can take a bit of time for these symptoms to develop and for people to seek help for them.
And also the parents.
I was going to say it's often
the family. Mustn't forget the family.
And the first responders, because what they saw was pretty horrific.
There are so many more questions to ask.
And the burnout of the therapists who are trying to do the work.
But thank you very much, expert panel. We've learned so much. You've been hearing from us individually as well, so sorry about that. You sparked an enormous amount of interest, I'm sure, in following up this very important topic. Thank you.
Thank you. Thanks a lot.